Thank you, Dr. Naroli, for the kind introduction. And as we are running short of time, I will go through the slides quickly. So, because the topic is very important. As you know, tuberculosis is a very contagious disease and affects mankind. And 1/5 of the world's TB population resides in India. And there are about 5,000 new TB cases occurring every day, and about 1,000 deaths are occurring daily due to tuberculosis in India alone. And as you know, with the advent of MDR TB and XDR TB, that is a extensively drug-resistant TB, there has been a more focus on development of new drugs for the treatment of MDR and XDR TB. And these slides have been provided by Cadre Labs, and these cover about the recent advances in tuberculosis and management of drug treatment of tuberculosis. And this talk will combine about the drug-resistant TB, new drugs and regimens, which have come in vogue for the diagnosis of TB, and on for prevention, the new vaccines which are under development. The first drug to be approved by US FDA in December 2002, a newer drug which is a bedaquiline, or called Sartoro. It shortens the culture time conversion from 77% to 57% in 24 weeks, and from 70% to 56% with conventional treatment in 72 weeks. The dosage is 400 milligrams daily for first 2 weeks, followed by 200 milligrams 3 times per week for 22 weeks. And as there is no cross resistance with ethambutol, pyrazinamide, and the moxifloxacin, and the amikacin and streptomycin, so it is being used as a second-line drug, but is not approved by European Union till now. Because it can cause QT prolongation, and so monitoring of ECG and liver function test is a must when you are using bedaquiline. But there is no adverse drug reaction with other anti-TB drugs, and it should only be used when effective treatment regimen cannot otherwise be provided. And it has a 2.5 higher morbidity compared to placebo, because it's a dangerous drug because of QT prolongation and liver toxicity. The novel combinations, I will come to it later. The second drug which has recently been discovered, or which has been introduced in the European Union, is a delamanide or Deltibia. It is approved for MDR TB by European Union in November 2013. The sputum culture conversion rates at 2 months are 45.4% versus 29.5% conventional treatment. The recommended dose is 100 milligram BD for 24 weeks, and it is undergoing phase 2 and phase 3 clinical trials in US, but it is not yet approved in the US or India. Another drug is sutezolid, or PNU 100480. This is a linezolid analog. It has a better antimicrobial activity and improved safety profile than linezolid, and there is no drug interaction with antiretrovirals, because as you know, most of these MDR TB are occurring with HIV patients, and so it is a suitable drug when you are treating a HIV patient with tuberculosis. It has the potential to shorten the treatment regimen also, and it is also undergoing currently phase 2 clinical trials in US. There's another drug is SQ109, which is analog of ethambutol. It is active against drug susceptible as well as multi-drug resistant strains of MTB, and the bacterial conversion is very fast, and it has a synergistic and additive action with INH, rifampicin, and second-line anti-TB drugs. It has a low bacterial mutation rate also. The mutation rate with this drug is low. So the tubercular bacilli has been found to have low mutation rate when this drug is being used. There is another drug in the pipeline which is called PA824 or pretomanid. It is a potent bactericidal and sterilizing action. And it's well tolerated at 100 to 200 milligram doses. It has synergism with moxifloxacin and pyrazinamide. It has also the potential to shorten the treatment for tuberculosis, and it has no significant cytochrome P450 interactions. And so it's a useful option for patients co-infected with TB as well as HIV. And is currently undergoing phase 2B and 3 trials in the West. Moxifloxacin, which is a common drug which fluoroquine which are using daily in our practice, this also has a role in drug-sensitive TB. Apart from MDR TB, the role of moxifloxacin is being investigated in the treatment of drug-sensitive TB also, as an alternative to INH and ethambutol, and to shorten the duration of treatment to a minimum of 4 months, because the minimum treatment we are giving is for 6 months, and moxifloxacin has a potency to decrease the treatment to 4 months. There are some trials with moxifloxacin where the containing moxifloxacin regimen was better than the conventional treatment. In the first, we are giving 4 drugs, the conventional 4 drugs, and continuation phase was with rifampicin isozanide. And in the second, we are finding that 4 drugs were being used in the intensive phase, which included moxifloxacin instead of pyrazinamide. And the continuation phase was with HRM or isoniazide, rifampicin, and moxifloxacin. And the third was with moxifloxacin, rifampicin, pyrazinamide, ethambutol. And the continuation phase was with moxifloxacin and rifampicin only. 2 drugs were only used in the continuation phase. And the conclusions of this was that moxifloxacin containing regimens has a better bactericidal activity than standard control regimens. And it has a potential to shorten the treatment to 4 months, and it was very effective also. And there was no significant difference in adverse events with the conventional treatments. So but still the 6-month duration remains the gold standard, but trials have been going on to reduce it to 4 months. It has a role in shortening the treatment duration, and 4 monthly, thrice weekly regimens also of moxifloxacin, gadifloxacin with the conventional HRZ was found to be inferior to standard 6-month treatment. So 4 monthly, thrice weekly treatment is not good, and the daily treatment with moxifloxacin is found to be better. Then there was a study called STAND or global, which was shortening treatment by advanced novel drug treatment. As you see, the drug treatment for this drug-resistant TB covers about 14,000 pills with daily 450 enzymes, and also reduces the expression of P glycoproteins. And this ensures that a high and sustained level of rifampicin is maintained, and there is improved sputum conversion rate also. And it also reduces the GI side effects, because of the dose of rifampicin is less in this, because only you are using 200 milligrams of rifampicin. The serum, as compare the rifampicin with the rizorin, serum rifampicin levels with rifampicin are low and variable, but it is high and sustained with rizorin because of the addition of piperine. And the GI tolerance is also better with rizorin, and the risk of hepatitis is also reduced with the use of rizorin. And because of this profile, the treatment adherence is also high, because many patients, because of the side effects of rifampicin, tend to leave the treatment in between. The benefits, because of better tolerability and improved patient compliance, rizorin is being used, and because of this, there is low treatment failure and reduced relapse rate also, and the minimized risk of development of drug-resistant TB also, because the compliance is better. It has preferred treatment for drug-susceptible pulmonary and extrapulmonary tuberculosis, and which conditions which are known to decrease rifampicin absorption. And patients who are not likely to tolerate 450 milligrams of rifampicin, you can use rizorin. And it is ideal switch therapy for patients who develop intolerable GI side effects or hepatotoxicity with conventional 450 milligrams of rifampicin. And also it's a good option in where drug-induced hepatitis, and in patients with who are alcoholic, elderly, malnourished, or having hepatitis B and C, where you cannot use high doses of rifampicin. Now coming to the newer advancement in diagnosis of TB. As you know, as the tubercular bacilli enters the body, there is the immune response, which can be either a cellular immune response or humoral immune response. And the presence of tuberculosis bacteria as such can be demonstrated by culture-based test or nucleic acid amplification tests. These are the newer newer tests which are being introduced, which has been introduced, with a liquid culture or bacteria test, where with a commercial broth-based culture system detects TB bacteria. And this, the next is the gene expert device, which is multiplies the DNA amplification test, and it is an automated test. And there's another molecular line probe test, which is for MDR TB and extended relief, XTR TB also. That is MT BDR. That is also a new test for extended for diagnosis of XTR TB. And there's another strip specification test. These are all DNA amplification tests. Gene Expert, this has been introduced about 2 to 4 years back. It is a fully automated test, and which amplifies the DNA, and which also conventional rifampicin, particularly those who do not tolerate 450 milligram doses of rifampicin. Thank you.